Okay, for the purposes of this assessment, normally we would wash our hands and put on a pair of gloves before we do anything, always thinking of our safety first. Okay, this is going to be a respiratory assessment. So, good afternoon, my name's Julia Tihuia, I'm from AUT. What was your name?
Stephen Charles Tihuia.
Okay, and whereabouts do you live?
I live in Turu.
Okay, well that's very good. Today we need to perform a respiratory examination on you, will that be okay?
Yeah, that's fine with me, yep.
Okay, so there might be some parts where I need to touch you and it may be uncomfortable at any point. Is that okay? Just tell me if you're uncomfortable.
That's fine with me, yeah.
That's good. Okay, so before we start, can you tell me, are you in any pain?
No.
Okay, no pain, that's good. Would we please expose your chest if that's okay?
Yes.
We'll keep that exposed for the purposes of today's exam. Thank you. That's good. So, as we do our assessment, before we start, I'm just going to have a general look around the room and make some observations. So, looking around the room, the patient's tidy, well kept. There's no signs of any medications like oxygen that would indicate that he's has any respiratory disease. Okay. So, on looking at the patient, my general observations, we always start with looking at ABCs, that's airway, breathing and circulation. So looking at the patient, he has an airway because he was able to talk to me. Okay, so breathing, looking at the patient, he's sitting comfortably at rest, not in any distress, not using any accessory muscles to breathe, and he's not sitting in a tripod position, which would indicate that he would be needing maybe shorter breath and that would help him. Looking at the patient, there's no obvious signs of diaphoresis, no scars indicating previous surgery, there's no medical alert bracelets or medical alarms. Looking at the patient, his tummy looks soft and he's got no pedal edema in his ankles. So those are all good signs. Okay, so if the patient was looking pale, then that could be a sign of shock, as is if he was a flush colour, he could have sepsis or anaphylaxis or something like that. So he has none of those. So we're going to carry on with the exam. So to start with, we'll be able to hold hands, Stephen. Just hold my hands. That's good. Give him a good squeeze. Oh, that's good. So feeling on his hands, it's good. He's got a good GCS. He's able to obey commands. His hands are warm and dry. Okay. Feeling over, I'm just going to feel your pulse on both sides of your arms. That's great, he has a strong regular radial pulse on both sides, so that's all good. If the patient had an irregular radial pulse, that could indicate a disease like atrial fibrillation, where the electrical current in the heart starts at the AV node instead of the SA node, so it doesn't fire properly. Okay, so if the patient had a really fast radial pulse, that could be a sign of shock or some kind of stress response. Likewise, if he had a weak radial pulse, that could be a sign that he had a very low blood pressure. Okay, so if I couldn't find a radial pulse here, I would check his brachial pulse up here. That's good. And if he didn't have one there, I would try for his carotid pulse up here. Okay, so that's good. So, can I have a look at your hands, Stephen? So turning them over, looking at the fingernails, there's no sign of tarring, so he's not a smoker, so that's good. There's no clubbing of the fingers. So clubbing of the fingers quite often occurs in somebody that has a congenital heart disease. There's certain diseases that have a missing chromosome that could cause that. So he doesn't have anything that suggests that. Okay, so can I get you to hold your hands up like this? Okay, so looking at the patient's hands, he's able to hold them up nice and steady. There's no tremors. We can put them down now. No tremors. So if there was tremors, that could be indicated that he was on a B2 agonist, like Ventolin inhaler for respiratory disease, or it could mean that he was a CO2 retainer. So there's nothing to suggest that because there's no tremors in his hands. That's great, thanks Stephen. Okay, so I just need to have a look at your neck now, Stephen. So I'm looking to see the jugular vein down here. So a raised jugular vein here could mean that he's got extra pressure on the right side of his heart, so the right side of his heart could be failing. Today there's no raised vein down here. I'll get you to turn to the other side. That's all good as well. Okay, so there's no sign of distress there, so that's really good. Just need to palpate your trachea down here. Okay, so that's good, it's nice and central. So if it was off to the side, that could indicate a pneumothorax, where there's a air has got into the pleural space of the lung, causing the lung to collapse. So there's no sign of that. So you can relax there now. Thank you. Okay, so I'll just go and grab my stethoscope. Okay. So I need to have a listen to your chest now, Stephen, is that okay?
Yes, that's okay with me.
Okay. So I'm listening for any odd sounds, any wheezes, crackles, that sort of thing. So I want you to breathe in and hold your breath briefly and then breathe out. So breathe in, out. Breathe in, out. Breathe in, and out. Breathe in, out. Breathe in, and out. Breathe in, and out. So turn this over to the other side. Breathe in, out. Breathe in, and out. That's really good. Okay, so I just need to have a feel of your chest to make sure there's no lumps or bumps or crepitus or deformities. Okay, so just feeling down here. Okay. No obvious lumps, crepitus or deformities that could indicate that he had broken ribs or anything like that. Okay, so that's really good. I'm just going to put my hands around your chest here. I want you to take a big breath in and out. That's good. Nice and symmetrical, both sides are equal. So when I listen, equal air entry on both sides, which was really good. Okay, so I just need to do a little bit of tapping on your chest. So it might be a little bit uncomfortable. So I'm going to work down your intercostal spaces here. Okay. That's good. No dull sounds there. That's really good. Okay, so I need you to sit up, please, Stephen, and so I can have a listen and I'll look to your back if you just lean forward. Okay. So looking at the back, there's no obvious scars, deformities, lumps, crepitus, bumps, anything like that, or bruising. Okay, I'm going to put my hands around your waist, get you to breathe in and out. And that's nice and even and symmetrical on both sides. I'm going to have a listen to your back now. You breathe in and out. You breathe in and out. Breathe in, out. Breathe in, out. Breathe in and out. Breathe in and out. It's actually better to actually listen to one side and then listen to the other side. In, in, out. That's good. So both sides are the same, so that's really good. Can't hear any wheezes or any crackles or any abnormal noises. You can sit back up there, please. I'm going to do that again on your chest. This time I'm going to get you to say 99. Okay? Okay, 99?
99.
99?
99. 99. 99. 99. 99.
That's good. Nice, good resonance there. That's good. Thank you. Stethoscope down. Okay. So in summary, the patient's not in any respiratory distress, got not using any accessory muscles, not having any trouble breathing. Okay. On auscultation, the anterior and the posterior, both clear lung sounds, no added abnormal sounds, no wheezes, no stridor, no crackles or anything odd. Okay. Good vocal resonance. No dullness on the tapping. In order to do a complete assessment for shortness of breath, we need to decide differential diagnosis. We need to get a full medical history of the patient, past and present, and find out if he's allergic to anything, whether he's on any medicines, whether he's compliant with his medicines or whether the doctor's changed his medications recently, that sort of thing. How he's been feeling up until today. I note that the patient only uses 2 pillows to sleep at night time, so that's not suggesting that he has trouble with shortness of breath in the evening. Quite often people with heart failure in the evening, they'll need lots of pillows to sit up because of all the fluid that's sitting in the bottom of their lungs. It makes them short of breath if they lay down flat. So he doesn't seem to have that problem. We would find out what his food intake was and was he drinking enough water. We'd find out whether his bowel and urine habits were normal. Urine infections are a common cause of shortness of breath. Signs of shock. We'd make sure that he hasn't had any recent falls or any trauma that could cause him to be short of breath. Many different reasons for short of breath, and we'd have to do a thorough examination. Always with taking our vital signs, we need to reassess and keep monitoring against the first lot of baselines. We need to have a 12-lead ECG to make sure that it was not a cardiac problem. Okay, so the patient also has a normal GCS, so he's alert, orientated. If he was not alert and orientated, he's sitting there with his eyes shut. Would he open his eyes to my voice? Did we have to inflict pain, or was he unconscious? The patient was unconscious at any time, then we need to treat the airway first. That's always our priority. Another thing that we didn't do was assess the cat refill time, so we can do that. So over 2 seconds indicate that he might be poorly diffused. Just check your cat refill now. That's good, it's less than 2 seconds. So that's all for today. Thank you for coming in for your respiratory exam.
Thank you.
Okay.
Well done.